Very good evening, everyone from India and those who have logged in from abroad. Today we bring a new concept. Today we are going a webinar panel discussion on preparation for practicals. For this webinar, we have respected examiners from different zones of India, moving from north to south, keeping the spirit of CCI, all for one and one for all. From Jaipur, we have Dr. Vikas Pilaniya, who is a DM in pulmonology. Then from Nagpur, we have Professor Dr. Radha Munje. From Hyderabad, we have Professor Dr. Pradyut Waghray. From Alappuzha, we have Professor Dr. PS Shajahan. They are going to solve the common dilemmas and the uncommon dilemmas all students face while giving a practical exam in respiratory medicine. My name is Dr. Atri Gangopadhyay. I come from Ranchi, Jharkhand, and this is a small presentation on how I saved time in the practical examination. Because we all know while doing that long case, there is some time issues. So if we know some certain shortcuts where we can save time, then it is going to help us all. Please remember, a practical postgraduate examination is like the dialogue Neil Armstrong said, that it may be a one small step for man, but it was a giant leap for mankind. Similarly, a practical exam for a postgraduate exit is not just a small exam. It is the giant leap that catapults a student from a struggling, average, middle-class doctor to a famous, elite, rich doctor. Once you clear that practical exam, everything can be yours. So that should be your determination when you're attempting for that practical exam. Suppose the patient was comatose and the history was given by the attendant. Please mention that. Suppose you had gone to a different center where the state language is different or the patient speaks a different language, then please mention if you needed an interpreter. Respiratory examination requires a patient to sit or stand upright. So if the patient was unable to sit or stand, please mention. And unfortunately in India, there is a bias against left-handed people due to a cultural bias. So please mention if you're a left-handed person at the very beginning. We all have seen this sequence, that general examination, inspection, palpation, percussion, auscultation. But when the time is short, we need to innovate and make some of our own methods. I have made this rule of 4. When we go to an undiagnosed case and time is short, then if you use this rule of 4 in respiratory system single pathology, this will clinch the diagnosis in over 90% patients. What is the first rule? Look for symmetry, because certain diseases in chest are symmetrical, certain diseases in chest are asymmetrical. Next, look for clubbing. Third, look for a plural tap, either in the present or in the past. Fourth, auscultate. We are carrying that stethoscope since we entered medical school, so we are definitely good at it and comfortable using. And auscultation means both respiratory and cardiovascular system. So if we use these 4 rules, automatically we get chance to a diagnosis. So then our sequence would be rule of 4 including auscultation, followed by history, followed by general examination. After that, do inspection and palpation together. Because please remember the first sentence of palpation, all inspectory findings are confirmed by palpation. And at the end, you do the percussion. Why? Because for percussion to be successful, it must be very painful. So please do it at the end. But while mentioning to the examiner, then mention the proper sequence as tradition. But for your saving time and getting the diagnosis, follow this sequence which I am telling you. General examination, certain tips how we can save time. Put in the thermometer for 2 minutes for measuring temperature and utilize the 2 minutes to look for pallor, icterus, cyanosis, edema, other relevant things. And after the 2 minutes, then you measure the remaining vitals. Very important dilemma. How do we practice palpation of trachea? Because if you have not practiced it, it is very difficult to say honestly. So seek out cases of massive pleural effusion where we know that the trachea is pushed. Seek out cases of massive volume loss where we know that the trachea has to be pulled. And only after you practice palpation followed by X-ray confirmation repeatedly, you will do good in the exam. Because if you mention it wrong in the exam, it is considered a very bad blunder. And either you talk left, right, central. Never say that it is slightly left or markedly left or grossly deviated. Either left or right or central. Another thing, tactile vocal frequencies is very difficult to appreciate. So always confirm it with vocal resonance. So please do both of them together to save time. Measurement of the hemithorax is compulsory wherever there is asymmetric disease, but you may skip in symmetric disease. The pathological side has a decreased movement. If there is a decreased hemicircumference and decreased movement, that is volume loss. If there is an increased hemicircumference and decreased movement, that is volume gain. And very, very essential in asymmetric pathology. Please practice percussion, one patient every day. The position of the patient hand when you're percussing from the front, when you're percussing laterally, when you're percussing from the back is very important so that you can perform percussion confidently on D-Day. This is also considered a blunder if not properly performed, especially in the case of pleural effusion. How do we recognize a bronchial breath sound? A bronchial breath sound is characterized by increased vocal resonance, increased femmitus, bronchophony, whispering pectoraloquy. So wherever you suspect bronchial breath sound, get all these four done together immediately. So ultimately, when you come to the final diagnosis, we have to use 4 parts: anatomical, pathology, etiology if possible, or suspect the etiology, and 4th, complication and comorbidity. For example, suppose there is a case of pleural effusion. Anatomically, we will say this is the asymmetric pleural disease. Pathology, pleural effusion. Etiology, possibly due to tuberculosis. Complication and comorbidity with untreated diabetes mellitus. So let's move on to the panel discussion now. We have assembled a set of questions, all given by the various examiners from their over 2 to 3 decades of practice and experience of taking examination. Let's go to the panel. So this was basically how we can save time in the practicals. Now we shall come to certain questions. Some of these questions I have received from students pan India that they never found the answer of these questions in book, or let's say there was discrepancy. And some question, the examiners in the panel today, they have been kind enough to share that they found students fumbling the most in this question. Once again, before we start, what I want to say, preparation for practical cannot be done in one day, but we have tried the next 1.5 hours to be maximum yield for everyone. So my first question to Dr. Radha Munje madam, which are the common long cases I must prepare? Means which cases I cannot do without preparing them thoroughly.
Thank you, Dr. Atri. Can you hear me? Yes. Thank you, Dr. Atri, and that is a very important question. I must tell you the background of this question. What does the examiner want to assess you for? So, whenever cases are chosen, usually the examiner himself evaluates the patient for particular obvious signs in that patient, which he would like you to detect or demonstrate or not miss when you examine the patient. And likewise, the cases are chosen. Most commonly for long cases, we have typical cases of pneumonias, COPD, a patient who has demonstrable signs of collapse, pleural effusion, pneumothorax, a case of fibrosis, and if it's a fibrocavitary disease, much better. And of course, a case of lung malignancy who either has obvious signs or signs of SVC. Such are the, or many times obvious findings of ILD if there are there, because in long case you are taking a history also, and you should be able to correlate the history and the examination and then come to those 4 points told by Dr. Atri in coming to the diagnosis. So we usually prefer to have cases which will have typical signs and which would facilitate asking questions and discussions. We want to see how the students are interpreting the findings and correlating it with the history.
Thank you. Very clear, very relevant. My next question to Dr. Pradyut, sir. The 2 years of COVID changed the postgraduate training curriculum. The 2 years of COVID changed the way the exams are being conducted. So, what are the post-COVID sequelae that can come as exam cases?
Thank you so much, Dr. Atri. I think one of the most common post-COVID sequelae which can be kept is post-COVID fibrosis, because that is what they can ask you in the examination, as Madam has told earlier, is how to elicit the signs of fibrosis on this case. Then they will ask you how you differentiate this from idiopathic pulmonary fibrosis. What are the points against and for it, because you are taking a full history of the patient, in which you have to also ask history about smoking and history about other autoimmune diseases producing the fibrosis of the lung. And then if there is a positive history of COVID, then you point towards a post-COVID fibrosis. Then in this case, they may also ask you about, as they go deeper in the examination, they can ask you about what exactly is happening in the pathogenesis. Is there a constrictive bronchiolitis, or is there a diffuse alveolar damage, and so on. And then they will ask you, how do you manage these cases? And the other conditions, apart from the most common I felt, is the post-COVID pulmonary fibrosis. Other conditions which may be asked, either in as a long case or in the orals, is the causes of breathlessness post-COVID. It can be due to the constrictive bronchiolitis causing breathlessness. It can be due to a microthrombi producing breathlessness. We are seeing many cases presenting as cough with asthma who responds to airway, inhaled corticosteroids. So these can be the questions in the orals. But I think as far as long case is concerned, the commonest case which can be given in a post-COVID sequelae is a post-COVID pulmonary fibrosis.
Thank you. Thank you. Now I would move on to Dr. Shajahan, sir. Many students complain that in their years of residency training, they hardly see cases of lung cancer. All of a sudden, at the time of exam, there is a burst in lung cancer cases. So what are the various presentations of lung cancer that can be an exam case?
Thank you, Dr. Arti, for the kind invitation, first of all. If there is a malignancy case in our ward, definitely and naturally it would be kept as examination. And when malignancy can appear in many ways, but if you wanted to keep it in exam, especially as long as, it should have features of mass lesion or collapse, or a pleural effusion, which is usually large with the central mediastinum, no mediastinal shift, with or without associating pericardial effusion, or cases such as pancostytro with the features of superior vena cava obstruction. These all can be kept as long case. Definitely, I can say for sure that, and Radha Madam, all these panelists will agree with me. If there is a case of lung malignancy in the ward, most likely it is kept as a long case or short case. And in case centers where Oski is being conducted as part of examination, especially in the DNB examination, if there is a lymph node enlargement, secondaries, definitely we can put it as Oski. And clubbing, as you said earlier, clubbing without as you said, it is usually we pick up lung malignancy 1 or 2 cases every week, or else it will be in the medical ward. People will pick up, our skill assistants will pick up from various wards, and definitely students cannot tell that I have not been seen a lung malignancy during my 3-year residency as a Pulmo PG. No doubt, if there is a case, and or not
There is network issue. You
definitely,
can
these
talk
are the presenting features which we usually get at the exam.
Okay,
Yes.
thank
And
you.
shall we add something to this?
Yes,
madam,
please,
yes.
Dr. Radha.
The purpose of keeping these cases of malignancies are because, all malignancy can mimic all types of respiratory disorders that you get, and you should not be mislabeling any patients for other disease whenever there is malignancy. So what is obviously there, like clubbing, the palpable lymph nodes, the visible veins, Horner syndrome, change in voice, all these things must
Yes,
be
sir.
taken into account and noted down.
And the consult, and being a budding consultant, they should be able to pick this up in the early stages. So
Yes.
definitely these are important.
Yes, yes. That is what the examiners expect them to pick it up very early.
Okay, now I will move on to Dr. Vikas. Some students gave me the argument that can I take my mobile to the exam because it can act as a torch, it can act as a calculator for measuring BMI, etc. So obviously a mobile phone is not allowed in the exam. Yeah. But Dr. Vikas, can you give us a list of instruments I must carry for that practical exam?
As you said that mobile is clearly banned in exam, that there is no one will allow the mobile phone in the exam. But you should have a complete instrument kit with you to save your time in exam. Most of the time, we can see the students are borrowing small instruments from the colleagues, and they are wasting. They will waste their precious time. So before going to the exam, you should prepare the complete kit of your instrument. And first of all, you should have a good stethoscope, one torch, one measuring tape, either 2 scales or 2 boards to measure the LPN lateral diameter, the thermometer, and the hammer for reflexes. So you should have a complete kit of instruments with you, and one more important thing, that skin marking pen also you should have with you. Most of the time we can see the students mark the skin with ball pen, and it's very painful to the patients when they are marking the boundaries and all with pressing the ball pen against the skin. So it's very painful. So you should have a proper skin marking pencil with you.
Okay, thank you.
So mobile is
now,
not allowed at all in the exams.
okay,
I
I
think
would want to.
mobile should not be allowed for examiners also.
Yeah, fair enough, fair enough. Fair enough. No mobile from either side.
Yes.
Great. Dr. Radha ma'am, whenever we read that WHO global burden, we are very happy to see that one pulmonary disease, COPD, is always trying to be at the top. So we know that every pulmonologist will get some COPD patient in career, even after passing out.
Yes, yes.
So madam, could you please tell for the students, what are the clinical signs of hyperinflation in a case of COPD?
Yes. See, most of our students see all these cases day in and day out, and they have even managed emergencies with cases of COPD. So whatever I'm going to tell is just either a revision or just trying to put all points together for a particular patient. And whenever we talk about hyperinflation, what does it mean is that more amount of air is going in the lungs than it is coming out. And this is happening for a long, long time. So the changes which come in the thoracic cage or even in the underlying lungs is almost permanent. So what do we see whenever there is hyperinflation in COPD is the first and foremost, when you look at the patient, you can see that the cricosternal distance is increased. How much should it be? That it should be only allowed to have 2 fingers of the patient himself. If it is more, then cricosternal distance is increased. Then you have to be very particular and you have to examine the patient properly, fully exposed thoracic cage. And then you would really appreciate that the chest becomes a barrel shape. Barrel shape यानी क्या है? I would take help of Evan Berger here. उसने जो barrel percuss करके हमको percussion सिखाया, that is the shape of barrel. So it is uniform and a convex contour outside of the thoracic cage. It is not only laterally, it is also anteriorly and posteriorly, and more evident anteriorly. So that is the barrel shape. Then when you examine the patient, the apical impulse may not be visible, which is otherwise very well visible. Then when you observe, the respiratory movements will be decreased, more so at the bases. And what happens is that the cage moves as a whole. It is not the movement of the thoracic wall. When you palpate and when you go to confirm all these findings of inspection, you would see that the chest expansion is decreased as a whole. It's not necessary to see all the hemithorax. It would be decreased as a whole. When you palpate, the impulse which was not visible may not be palpable, right? Then when you measure whatever has been seen visually as a barrel-shaped chest, you would appreciate that epidiameter is increased in these patients. So these are the things which you are looking at. Okay. When you go to the percussion note would be hyperresonant, but not as hyperresonant as you note in the patients of pneumothorax. So you have to make a habit of percussing, as Atri has already said, that you must percuss every day, so that you are able to make out the percussion note. And when you percuss, you would also observe that the upper border of liver dullness has been displayed down. And when you auscultate, the breath sounds would be decreased, a wheeze will be heard, and you will not get adventitious sound unless there is some amount of secondary infection which has happened, or if this COPD is not a pure airway disease but is a sequelae of some underlying disease, then only there would be crepitations which can be heard. Importantly, you have to also assess that post-expiratory time will be increased in these patients because expiration is prolonged. At the same time, when you observe, जैसे अत्री ने बोला है कि आप temperature लेते हो, तो in that 2 minutes, you have to observe all the things. Now, this patient of COPD may be stable, may not be stable because of either severe COPD or he has some exacerbation. So at the same time, you have to look that when he's breathing, is he tachypneic? Is his expiration prolonged? Then does he have a pursed lip breathing? Is there any intercostal indrawing present? You have to look at all these things and make note of all the findings that you get.
Thank you.
And
Dear
students,
students,
I think I forgot was, rather did not mention was that when you try to mark the cardiac dullness, at that time also the lateral, left lateral wall may not be, and left heart border will be percussed nearer to the sternum.
dear students, these words of wisdom are not for one book, but they may be from over 20 books, which Madam has taught over the last quarter of a century and more. So these are words of wisdom. These are golden words. Please stick to it. You will never find such a beautiful conglomeration ever. Now moving on, I would want to go to Dr. Pradyut sir. A pleural effusion can often be a Pandora's box because many diseases can give rise to a pleural effusion. It may be from the chest. It may not even be from the chest at all. So, what components of general examination are important in a case of pleural effusion?
You are absolutely right. A case of pleural effusion can have a number of causes, transudate, exudate, and exudate. There are so many causes. Our aim is to, when you take a history, you get an idea this patient may be having pleural effusion. So our idea is to come to a diagnosis in finding out the etiology of the effusion. So if you start and make it a habit to start from the head to toe, you will not forget anything, any cause which is related to this etiology of the pleural effusion. For example, you start with the eyes. Is there any yellowness of the eyes? Is there any icterus? Is it linked to the liver? Is it hepatic hydrothorax, or is it some other liver metastasis which can cause effusion? Then as you come down, you look for the JVP. Is it elevated, or is it pulsatile? Is it non-pulsatile? Is the patient in congestive cardiac failure? Then when you come down, you look for the cervical and the supraclavicular lymph nodes. Are they soft, matted, so pointing towards tuberculosis? Are they hard, fixed, immobile, pointing towards malignant etiology? Like that, you come, then you slowly come down and come to the hands. As Dr. Atri has said already, the importance of clubbing cannot be underemphasized again. Look for clubbing, and there are so many respiratory causes and cardiac causes of clubbing, and then try to correlate your findings. Whether is it a malignancy? Is it some sort of interstitial lung disease, or is it some sort of an empyema which is there because clubbing is there? Then once you check the hands, look for any joint deformities. Is there any rheumatoid joint deformity? Is there any history of deformed joints or any other skin pigmentations on the hands or any face as well? Then when you come down, abdomen and chest, is there any prominent veins, as Madam has said already, any prominent veins on the chest wall? Is there any hepatosplenomegaly in the abdomen, or is there any ascites? And then is there any evidence of caput medusae? Then as you come down, always examine, don't forget to examine the genital examination if the patient allows you to do. That will also help you to get many points in diagnosis. Then as you come down to the lower limbs, look for any edema of the feet. Is it unilateral edema suggestive of a DVT, which is a cause of a effusion? Is it a bilateral edema, which can be due to a congestive heart failure, or it can be due to a hypoproteinemia or any other? Look for also thyroid. I forgot one point here. So I think if you make it a habit of going from head to toe, you will get so many points which can easily help you in coming to an etiological diagnosis of the pleural effusion.
Thank you. Very exhaustive. And we shall again come back. I have one audience question, Dr. Pallav Bhattacharya, and he is doing DNB from Metro Hospital under Dr. Talwar sir. And we all know recently he came first in the NAPCON quiz also. So we all met him in the NAPCON quiz final. So his respiratory practice is on 18th of June. And is it going to be a virtual case presentation or normal physical? See, that is something which we cannot speculate. DNB board will give you in writing that what will be your exact exam pattern. But here's another question. What should be my strategy for Oski exam? I would request Dr. Shajahan sir, if you could kindly tell Dr. Pallav that what should be his strategy for Oski exam?
Well, around half of the marks are awarding from Oski only. The clinical examination carries only 50% of mark. So your marks in the Oski is very, very important, and your clinical scenarios which people can ask us Oski. In DNB, I believe it is the Oski is from central board. It is coming as virtual, not physical. So there are so many training manuals in which so many cases, virtual case series are being. They earlier said when one cannot prepare for Oski. So anyway, your Oski is on next 18. You prepare with these kind of manuals, thorough with many questions from your colleagues, teachers, and these kind of manuals, and go well prepared. That's all the thing I can say at this point of moment.
Yeah, wonderful. I would want to add in a very simple point. The way of asking the questions have changed, but the actual question have not changed. Before COVID also, we used to have two lungs. After COVID also, patients have two lungs. Before COVID also, we used to do inspection, palpation, percussion. After COVID also, when you see a patient in real life, you will definitely do inspection, palpation, percussion. So the Oski will ultimately ask you questions from your 3 years of residency regarding how you manage problems, how you manage emergencies, what may be the most common drugs, etc. So the pattern has changed does not mean that our subject has changed at all. Means pulmonologists are not going to be doing angiography or laparotomy or Colles fixation now. So don't worry. Concentrate in pulmonary medicine, and you're a NAPCON champ, man. You won that NAPCON quiz. So all of you are going to do wonderful. Don't worry. My next question to Dr. Vikas, sir, Dr. Vikas Pilaniya. Many students are very happy when they appreciate that Velcro crackle, which may be diagnostic of DPLD. But other than that, what? So I would request you to kindly enumerate the positive findings in a case of DPLD. You need to unmute yourself. You're muted yourself.
Actually, DPLD is a very vague term. It's having a multifocal etiology. So first of all, we should examine our patient thoroughly, not for respiratory system, but also for other systems like neurological, cardiac, and other system also. When we start from history, the patient will have a typical history of dry cough and dyspnea or exertion, and it is typically on gradually progressing type of disease. On inspection part, if the patient is having progressive DPLD, we can notice the cyanosis and clubbing in these patients. And sometimes we can have the signs of complications also, like if patients having CHF, we can notice the pedal edema and also other symptoms. When we go to the inspection part, usually the patient is chest is bilaterally symmetrical, and patient is most of the time is cachexic, having cachexic loop. When we go to the palpation part, we will have the decreased chest expansion but bilaterally symmetrical. There is no asymmetry in the case of DPLD. When we do the percussion part, we will appreciate the impaired notes, and the most important, as you said, is the auscultation part. In this part, we will hear the typical and inspiratory Velcro crepes. And most important features of these crepes, the intensity will not alter after coughing. The intensity will be same after coughing also. So these are some typical findings of diffuse parenchymal lung disease patients.
Thank you. A very important thing which Vikas sir told is look for the symmetry. In DPLD, we should expect a symmetry. Suppose the findings history is matching DPLD, but there is no symmetry. So it can be two diseases, or it can be a DPLD which has undergone a recent complication. So these are the fine things. The book will not train you. You need to train yourself on the day of the exam. That don't panic. Suppose everything is not going as per the textbook. Your findings are not as per the textbook. Don't panic. Don't try to make up the science. Say what you elicit. Fumbling is okay. Fudging is not okay. Yes. And now I would want to move on to Radha ma'am. I had this friend, we did MBBS together, and then she wanted to go to USA basically, and she was doing that medicine in USA, and even her HOD dean, they used to ask her that you are a pearl of wisdom in tuberculosis. Because in USA, we do not see tuberculosis. But in MBBS in India, you have seen so much tuberculosis. So Radha ma'am, how do I differentiate between pleural thickening and pulmonary fibrosis, both secondary to tuberculosis?
First and foremost, what I think, Dr. Atri, and for all is that we have to understand that pleural fibrosis is a result of some pathology in the pleural space or in the pleura itself. Whereas parenchymal pathology is a result of underlying parenchymal disease or the trauma which the parenchyma has undergone. So I usually explain my students that pulmonary fibrosis or a parenchymal fibrosis is parenchymal scarring. It's a changes which occurs in the whereas pleural fibrosis I personally feel is a true fibrosis because you can really visualize that fibrosis, take out the pleural peels whenever the thoracoscopy is done. Now we move to the actual question. Pulmonary fibrosis can occur in any part of the lung wherever there have been earlier damage, whereas pleural fibrosis per se would almost always, I would say, would start from the basis where the pleural fluid would accumulate and remain for a longer time. That is one thing. So, when you examine the patient, the first and foremost is again we see for symmetry, and you would observe that the chest may be asymmetrical. And the second important point, whenever you look for symmetry, is movements. So you would observe that the movements of the chest wall will appear to be decreased in the lower part, that is in the inframammary region, infrascapular region, and infra-axillary region. These are the areas which would show you decreased movements whenever there is pleural fibrosis. Whereas in parenchymal fibrosis, wherever is the involvement, that is the part which would be seen asymmetrical as well as with decreased movements. That's one thing. Then when you move on to inspection and you would be examining the patient and touching the patient, the first and foremost, what Dr. Atri talked about was trachea. And remember that pleural fibrosis leads to volume loss, no doubt. But parenchymal fibrosis, because it's scarring, would more affect the major airways as well as the underlying mediastinum. It's going to pull all this towards the site of fibrosis. And so when you examine the patient, the shift of trachea and mediastinum would be on the side of the fibrosis when you examine the patient, and it would be definitely associated with parenchymal fibrosis. Then whenever there is a parenchymal fibrosis and when you go ahead with examining the patient and you go for palpation and when you see for the vocal fremitus, then you would realize that it would be definitely decreased in parenchymal as well as pleural fibrosis. But if the fibrosis is of a process wherein the larger airways are coming nearer to the wall of the thorax, then at that time the vocal fremitus will appear to be increased. Such type of finding will never occur whenever there is a pleural fibrosis. I keep the forum open wherever I go wrong or I miss on something. Anybody of you can prompt me because we don't want to misguide the students, right? Our purpose is not to correct each other, but not to misguide the students. Okay. So that is what I have observed and I have learned that in parenchymal fibrosis, this shift would be observed. Then when you auscultate the patient, you would find that in pleural fibrosis, breath sounds would be grossly decreased or it may be even absent in the basis. Whereas in parenchymal fibrosis, you will always almost find adventitious sounds, which is not a feature of pleural fibrosis. So you may hear crepitations. Then when you have done all this, you must also remember to correlate with the history. Any patient who has parenchymal fibrosis has to have cough associated with expectoration either at the time of presentation or in the past when you take a history. There may be a positive history of tuberculosis or may not be there, But definitely patient will give you a history of recurrent respiratory tract infection with history of cough and expectoration, and sometimes the patient can even give you a history of hemoptysis. There would be a history of recurrent fever also associated with these symptoms. Whereas pleural fibrosis per se and pure pleural fibrosis would be limited to the pleura. So all this history and signs and symptoms will not be there. However, a patient of pleural fibrosis can always give you a history of pleural tapping, whether it has been done. And Dr. Atri has already underlined this. So, and then, अब अगर ऐसा पेशेंट है कि उसको हिस्ट्री ऑफ टैपिंग नहीं है, but if you take a proper history, he may give you a history of pleuritic type of chest pain for few days and then which disappeared because his pleural effusion was not diagnosed, not treated. However, he presented directly with a pleural fibrosis.
Thank you. That was
And sometimes,
very
of course,
exhaustive.
if there are recurrent infections, there can be clubbing, there can be halitosis. All these signs are depending upon the underlying lesion which the patient has.
Yeah. Thank you. I would want to move on to Dr. Pradyut, and I would like to
Forget
share
anything,
that.
you can elaborate, Dr. Atri, because students
Yeah.
should be benefited.
Don't worry, we shall come back. And Dr. Pradyut is a very proud father today because his son, Dr. Kunal, who had successfully completed MD Pulmonary Medicine, he has recently qualified as DM Pulmonary Medicine entrance. And after 30 years, he is again going to be a student for the next 3 years. So Dr. Pradyut is very happy today. So the question to you is, these people appearing in PG exit are often approaching 30 or cross 30 when the memory or memorizing capacity starts failing. So how can these students perform best despite these issues?
I think at the outset, I would like to thank Dr. Atri for the congratulations. Thank you so much. And I think, I give you a personal example of mine. I'm now 63 years. And I think if you do regularly some sort of a discipline exercise to your mind, not body, of course, we all do, but to the mind. That is, you do some sort of meditation or yoga, whatever you may call, where your mind relaxes. Give it at least 5-10 minutes, at least before the examination. I'm sure you will not lose your memory. You will have all the memory cells intact. But if you are one of them, you are scared, we lose memory or we think we're losing memory if we are in stress. Then we tend to get confused and even start committing simple mistakes in the examination. Okay, so first thing is that. But however, assuming that if you think that yes, I'm losing memory for whatever reason, what I suggest is at least before the examination, quite before the examination, jot down few points about each case. Say, as Madam has said, some vital points about pleural effusion, fibrosis, parenchymal fibrosis, whatever the cases are going to get, jot down some important points. Don't read for the whole night before the practical examination and confuse yourself. Just remember these points. Have a good night's sleep. Get up early in the morning, have a good breakfast, and then go peacefully for the examination. Your memory will not fail you. So in summary, relax, don't take stress, have a night's sleep before the examination, and make some points, just some jot down points to relax and revise before the examination. That is my take on this.
Chalo, very good. The best thing was keep it simple. That was the best thing. I would want to move on to Dr. Shahjahan, who had specifically insisted on this question because he often found students fumbling in this question or showing lack of confidence in this question. So Shahjahan sir, could you please talk about drooping of shoulder and what is pseudo drooping? And could you mention certain conditions where drooping can be reversible?
Well, those seems to be simple. Drooping often confuses students, even examiners. Sometimes the students may say there is drooping. One of the examiners say there is drooping. There can be so many confusions. But remember three things. One, you make the patient stand if the patient is able to do that. Look at the tip of the shoulders. One of the tip of the shoulders may be at the lower level. Then you can look at the inferior angle of the scapula, whether one of these inferior angle is prominent or not. Then look at the spino-scapular distance. If there is drooping, the tip of the one of the shoulder will be at the lower level. The spino-scapular distance on the affected side is reduced, and the inferior ankle of the scapula on the affected side is reduced. Sorry, prominent. So if 2 out of the 3 points are positive, we can say for sure fibrosis, collapse, pseudo drooping. Sometimes we may think that there is drooping. There is a confusion between the examiner and the student, the drooping or whether drooping present or not. See, then you ask the patient to stoop forwards or ask him to walk. If the drooping disappears, it is pseudo drooping. And look at there is any convexity of the spine. Usually convexity is to the opposite side of the drooping when there is a true drooping. But in pseudo drooping, it may be on either side. So that is what is about pseudo drooping. Then about you talk about reversible drooping. We think that when there is a drooping, it is a permanent damage. Not like that. Drooping can occur due to disuse atrophic pleurisy. What happens? There is painful spasm of the muscles, so there will be drooping. So when you the pleurisy is over, it will be reversed. You take empyema, there is toxic myositis, then there will be drooping. Once you clear the empyema, you manage the empyema properly in time, it will reverse. So that about reversible drooping. So though we think that drooping is a very simple physical sign, at times we find it difficult to say whether it's the true drooping, pseudo drooping. Of course, reversible drooping is a different issue. They are reversible. Sometimes the drooping may be partially reversible. For example, in a collapse case, if you remove the obstruction, the drooping will improve. All these things. So this is the I specifically asked you to put this question in the panel because this is a very important question. But many a time students find it difficult. Even many of the examiners confused because that is why I specifically asked you to do so. Thank you. I think
Thank you, sir.
Radha Madam can add on to that because Madam has more experience in this. The drooping.
In fact, I did not comment upon drooping when I was talking about fibrosis, especially because the question would come up somewhere and I didn't want to confuse the students. That's fine.
Thank you.
Okay. Now we will move on to Dr. Vikas, sir. Sometimes there is case of lung collapse, and we know that unfortunately the patient can also collapse from lung collapse. But the problem is sometimes the students collapse when they get case of lung collapse. So Vikas, sir, could you please guide how we can differentiate clinically between lung collapse of neoplastic versus non-neoplastic etiology?
Usually the lung cancer cases are very interesting, and in the malignant pleural effusion, the student may not get the typical sign of and symptom of lung collapse. Because the typical non-neoplastic lung collapse, the mediastinum and trachea will be shift on the same side. But if the patient having a collapse due to the endobronchial mass along with effusion, and if the effusion part is dominant to the collapse, the mediastinum may be shifted toward the opposite side. So you may not get the typical signs of non-neoplastic lung collapse. Most of the time, the neoplastic lung collapse is associated with pleural effusion, and in the malignancy, the effusion is usually massive. So we can get the signs of massive pleural effusion, not the underlying lung collapse. So the mediastinum may be shifted toward the opposite side. The intercostal distance may be increased. The affected side volume of lung Hemithorax may be increased. So it's very difficult in the malignant pleural effusion with collapse to differentiate the because sometimes the collapse part is predominant. so we can get the typical sign of collapse, but sometimes the effusion part is predominant, so we can get the sign of massive pleural effusion.
Thank you, Vikas sir. I find the audience question. I am reading it out because it is incomplete. And if you're hearing us, could you please completely type your question? Dr. Amarjeet Singh from Punjab Bathinda, you have asked, can we use steroids for long term? But you have not mentioned in which condition. If you could kindly retype your question and we shall definitely get back to you. So by the time he comes back, I have an audience question for Dr. Radha ma'am. And this is Dr. P. Ravi Kumar from Rajamundry. He is also appearing for his MD exam recently. And what question do we expect in polysomnography? What type of question we may be asked regarding polysomnography? Dr. P. Ravi Kumar from Rajamundry.
Yes.
Radha ma'am.
I think polysomnography would be an Oski station for your assessment. And in that Oski station, perhaps a well-defined sleep-related disorder would be displayed, and that would be kept for a question. That is one thing which is possible. And along with that, a short history would also be given. For example, Mr. X, age 55, body weight 120, gives history of dozing off and on, even when he's sitting in the office, history of snoring, history of gas. Such a history is given, and then PSG study, a record of short duration is kept there for you to read and comment upon. Most of the times, there would be a clear cases of obstructive sleep apnea, because these are the commonest one which you should be able to diagnose, and you should be able to pick up the hypopnea, apnea-hypopnea index also. So these are the common stations for Oski. Otherwise, they can even give you a more detailed history, and a graph may be displayed where you should be able to pick up leg movements which are associated during sleep, abnormal leg movements, or there may be central apnea, and the questions are framed accordingly. Like a patient is diagnosed to have OSA first, and patient is put on BiPAP therapy. Somehow his hypoxia is not responding, or it is increasing. And at that time, looking at the history and looking at the graph, which is after the titration, you should be able to make out the central apneas if they are there, or if there are obesity hypoventilation syndrome. So a question is framed, and based on the answer of that question, a graph of recordings of PSG would be kept. And then the relevant questions would be asked.
I think on MD level, no one will ask about the elaborated about the PSG questions. They will ask the simple questions related to the PSG, like indication of PSG, what is the obstructive sleep apnea, what is the hypoapnea, what is the central sleep apnea, what is the Pickwickian syndrome, and all.
Yes.
So I think examiner will ask the related questions, what are the common signs and symptoms of obstructive sleep apnea.
Elaborate history will be given.
Yeah.
It is not like you put up a chest X-ray and we ask you to read. उसके जैसा Oski stations polysomnography का नहीं रहेगा. There would be a good, short, relevant history given, and then the questions asked.
Yeah, I want to tell something from my experience. Oh, Shajahan sir, please.
Apart from Oski, this may be a patient with OSA along with
yes.
Or COPD or some other disease can be kept as a short case also. So it should be.
Okay, so I want to add something, that there are two schools of practicing sleep medicine in India. One is neurologist. They never invite a pulmonologist to their program. One is pulmonologist. We never invite neurologist to our program. Please remember that when we open that chapter of sleep test, there may be lots of boring things regarding EEG. You are not appearing for a neurology exam. So focus more on the breathing related questions. means where you can see that apnea, where you can see that hypopnea, where you can see a desaturation,
Yes.
where you can see a hypercapnia, rather than what may be the various EEG waves during various stages of sleep. That is secondary. If I, as a practicing pulmonologist, I fail to pick up a EEG wave, I am not wrong. But I should not miss what is apnea, what is hypercapnia. I should not miss those things. So that we should keep in mind in polysomnography. My next question to Dr. Pradyut sir. What is the role of upper airway examination in a respiratory case? Upper airway examination.
Upper airway examination, if you see the upper airway starts with the nose, the nasal cavity, pharynx, larynx, and then go to the trachea up to the where it just joins, goes interthoracic. It's important always because it can give you vital clues to your diagnosis. For example, look for ADNS, look for nasal stuffiness, look for any evidence of sinusitis. If you're having a case of bronchiectasis, probably it helps you to diagnose sinusitis. Look for any pain in the upper maxillary teeth, which can be a sign of sinusitis associated with bronchiectasis. Then as you come down in the upper airway, look for tongue, either macroglossia or any micronathia. And then look for any, soft palate or any uvula or the base of the tongue. Just now we talked about obstructive sleep apnea. Do the Mallampatti scoring. And if it is high, then it indicates towards, if your case is a sleep apnea, this becomes an important point. Secondly, try and look for any infected gums. That can give you a good idea about any, if your case is lung abscess, it is added in that point. Then look for any tobacco stained lips. If you're getting a case of bronchogenic carcinoma and a history of smoking is there, that can give you an added point. So these are some of the points where the upper airway examination will help you in getting or clinching a diagnosis, etiology of your case.
Yeah. There is a couple. One partner is pulmonologist, one partner is anesthetist. But I would want to tell them that the airway belongs to both of you. So Mallampatti scale should be remembered by both of you. Even if you are a pulmonologist, please know what may be the Mallampatti or modified Mallampatti. It should be memorized so that on the day of the exam, you can actually open the mouth and tell to the examiner, this is Mallampatti 1, 2, 3, 4, whatever. Now, I would want to move on to Shajahan sir. And this is an audience question by, let me read it out. Actually, what happens? We all know about a physiological blind spot. That blind spot is always there, we skip it. Similarly, what happens to students? They read a book for 2 years, 3 years, multiple times, but they skip a certain portion because when they go to reach that portion, either they fall asleep or a patient deteriorates in the ward or a boyfriend, girlfriend phone call comes for 30 to 45 minutes. So this gentleman, Dr. Advait Mohan from Delhi, he is asking regarding tidal percussion. That please guide us regarding tidal percussion, the applications and fallacies, because students complain they fail to find it in the book during the years of residency. Shahjahan sir. Please unmute yourself, sir.
Sir, you are not audible.
You're muted. Shahjahan sir, please unmute yourself.
Sorry.
Yeah. Yes.
Sorry. Yeah. If you know the physiology and what is happening to the lung while you are doing percussion, it's very easy. And as you said, you have to practice these tests every day. Then only you can say for sure, say, this is tidal percussion, or else you will confuse. You may say opposite of what is you mean. So what do you mean by tidal percussion? Is that tidal percussion is to differentiate a dullness which is due to either supradiaphragmatic cause, or you percuss from percuss downwards, you reach area of dullness, you ask the patient to take a deep breath, and if the previous area of dullness is resonant, that means the initial dullness was infradiaphragmatic. Probably in the right side it is liver dullness. Okay. If it is again dull, that means it is supradiaphragmatic, that is probably due to pleural effusion usually. But remember, this law is applicable only when there is no diaphragmatic paralysis. If there is diaphragmatic paralysis, there can be fallacies. But otherwise, in most of the cases, it is very simple. I once again repeat, dullness, you ask the patient to take a deep breath, and if it become resonant, the initial dullness was due to an infradiaphragmatic cause, and if it remains dull, it is due to a supradiaphragmatic cause. That's it.
Thank you. Thank you. We have an audience question from Dr. Frank Pichumathai, who is at Bhilai Steel Plant Hospital, and he is requesting Dr. Vikas Pilaniya, sir, if you can tell us about the postural variation of cough, dyspnea, and expectoration.
I think Radha Munje madam can explain better than me, because she is having vast experience in the clinical and teaching.
He wanted to know about postural
variation of
postural
cough,
variation cough, yes, and
cough for dyspnea and for expectoration.
Okay. Usually, you have to understand basically the physics of something. When we talk about physiology, it's always related with physics. And whenever we talk about postural relation, what are we really talking about? We want to determine which side of the lung is involved. That is one. Then secondly, what we are looking at is in that side also, what type of underlying pathology do we expect? Okay. So these are the two things which you are looking at when you talk any variation with posture. So now I'll take two different examples. One is an example where a patient has involvement of the lung parenchyma on the right side in the middle. Now when this parenchyma is involved, either it has a pre-existing bronchiectatic lesion which is secondarily infected, or there is a fresh lesion which is a cavitating lesion and there is either a necrotizing lesion or a cavity which is secondarily infected, or it can be even a cyst which is infected but is communicating with the airways. Now what happens that once the pathology is on the right side, if the patient is lying on the right side, what happens is that the draining airways are pointing up. So nothing happens to the patient when he is lying on the same side. Now, as soon as you ask the patient to lie on the opposite side, what happens? The airway which was pointing up has now become dependent. And what happens is that whatever accumulation of fluid, expectoration, necrotic material is there in the cavity or bronchiectatic segments, or that infected bulla or cyst, whatever, it would suddenly start flooding the airways. With this, what will happen is there will be a sudden bout of cough because all receptors are stimulated. There is flooding of airways with the fluids. So there will be cough. And secondly, patient will bring out expectoration after coughing because the airways which are now become dependent are allowing the fluid to come by the rule of gravity. So this is what is a postural cough and postural drainage, which allows you to diagnose what type of disease patient has, as well as in which part of the lung it has. All of you otherwise must be aware. Please, whenever the physiotherapist comes to your ward, look which positions he is giving for postural drainage. Because this test we are utilizing also in treating the patient when we offer them a postural drainage of a particularly involved segment or a lung part. That's one thing. Now, another example I would say that if there is a pathology in the airways, either it is on the right side or just at the carina, left side at the carina, or in the major airways. And if that growth is pedunculated, and it is moving with the posture, then also the patient would have cough on change of posture whenever this growth is obstructing the airways completely after the change of posture. So for example, there is a pedunculated mass attached to the posterior wall and patient is lying flat on the bed. Patient may only complain of either discomfort or breathlessness. No sooner does he get up or he bends forward, the mass would suddenly come in and occupy the whole of the airways or the larger airways, and patient would suddenly become breathless and he will have a bout of cough. But here, patient will not have any expectoration. That is one thing. And these are the cases which would also give you signs of either monophonic wheeze, or if you observe the, if you examine the patient properly, then you would get that particular sign where posteriorly you would get a bronchial breathing, and somebody should prompt me for that sign. It's on the tip of my tongue. I would recollect and tell my students.
Okay, thank you, Dr. Radha ma'am. Very well explained, and I'm sure now those of you this year who will get Radha ma'am as examiner,
It's
you should
dyspine
answer
sign.
it properly.
It's dyspine sign. It's the bronchial breathing which you hear on the cervical, the posterior vertebral column. Whenever there is either a mass at the carina or in that particular area, you would hear a bronchial breathing, which is called as a dyspine sign.
Great. Thank you. I would want to move on to Pradyut sir. What should make me suspect, either during history or examination, whether the patient may be suffering from any congenital thoracic defect?
The patients with congenital thoracic defect may present to us with either they may come to us with breathlessness or they may come to us with chest pain. These are usual complaints that come to us, and then we should look for any abnormalities seen either in the chest wall or in the muscles, or it can be even deeper in the lungs. In the chest wall, if you look for any signs of, for example, pectus excavatum, pectus carinatum, and these are the things which are very obvious on examination of the chest, and that can give us some diagnosis. This could be the etiology for his symptoms. Sometimes we may see, a congenital absence of the pectoralis muscle itself, which we can confuse with any pathology if an X-ray is given to us for discussion. So that has to be kept in mind. Then if your patient, we can present with either lung agenesis, and the X-ray may look us, we may tend to get confused with a pathological condition. Sometimes the patient can present with breathlessness on lying down. Then you can think of a diaphragmatic condition like diaphragmatic paralysis or diaphragmatic maldevelopment of the diaphragm. Or it can be a lung function test may give you where the FVC is reducing during lying down. So these are the few congenital conditions which you must be aware of when the patient is presenting you with breathlessness or chest pain of any, when you are unable to come to any other condition. Generally on your examination, you can pick up these findings. This is what I thought. Maybe madam or anybody else can elaborate on that.
Thank you. I would want to move on to Shajahan sir. Shajahan sir in government area has worked with the largest number of thoracic surgeons, and their pulmonary department is actually involved in lot of thoracic surgery cases also, either as coordination or as follow-up. So Shajahan sir, what are the various surgical scars on the chest?
Scars can occur as a part secondary to burns, healed skin conditions, etc., etc. But your question is on surgical scars. For example,
Yes.
surgical scars can be starting from sternal region, midline. See, that's there you see a scar on the sternal region, the midline. Most likely it is to a cardiac surgery, a coronary artery bypass grafting, all these things. But remember, if there is a scar on that, does not necessarily mean it is a BG. It can be a post-keloid also. Similarly, the keloid also notorious to occur in the midline in the sternal region. So that can be that may also one of the reasons. Then you can have some scars in the infra-axillary region we usually see, possibly secondary to our ICD drainage and all these things. or you can see subpectoral, especially bilateral subpectoral. I have not seen to lung both subpectoral region. Okay, then you can see some scars, especially in the left infraclavicular area. So this was secondary to the pacemaker insertion. But remember, any area you can have scars, secondary stab injuries can occur. Many injuries can occur, whether with the thoracic surgery intervention, surgical scars can occur for secondary to trauma, secondary to stab injuries, many things. But commonly secondary to thoracic surgery is in the midline as opposed to secondary to CABG, but in the axillary region or mid infraaxillary region or surgical or lung removal, whether for segmentectomy, lobectomy, etc.
Okay. Thank you, Shajahan sir. I had to disallow this question because someone had asked that which books I should study. See, in an open platform where there is recording, we cannot endorse or refute any brand. So that I would request you to ask personally to any of them. They will not object, but we will not answer this question on a public platform. Vikas sir, please guide regarding dress code for male candidate going to the exam.
Frankly speaking, there is no defined dress code for the exam, but your dressing sense, your clothing will put a impression, a great impression on the examiner. So, in the during the exam, you should wear a formal pant, shirt, shoes, a clean white apron, and you should have clean shaved if there is no religious concern there. It doesn't mean कि आप फॉर्मल उसमें जाते हैं तो एग्जामिनर आपको एक्स्ट्रा मार्क देगा, बट इफ योर ड्रेसिंग सेंस इज वियर्ड और ऑकवर्ड, दैट you will definitely lose your marks. So always in the exam, you should wear a formal dress code, simple dressing, and proper in a proper dressing sense, clean shave and with clean white apron. So
it is applicable to the examiner as well as it is applicable to the examiner as well.
Yes, sir.
Yeah, very good. It is actually applicable to the examiner as
also.
well. And
so your clothing will put a first impression on the examiner, and the first impression is always the last impression.
Okay. Now I move on to Radha ma'am. The ditto same question for female candidate, dress code, but please add regarding cosmetics, please add regarding jewelry also.
In fact, Dr. Atri, I appreciate this question, and this question has taken me back, I should say 40 years back, when we are students and we enter the dissection hall. The same thing which we have been taught, I always believe that you have to respect the bodies which are allowing you to touch and get an education. Similarly, in examination, you should respect the patient who allows you to examine him and allows you to step up ahead in your career during your exams. So the first and foremost is you will wear something which is acceptable to everybody, to you, the examiner, as well as the patient. So the question of using lot many cosmetics and jewelry does not arise, because you have to remember that anybody who is a patient is in physical as well as mental pain. So you cannot be, overdressed at the time of examination. At the same time, I would advise that I would not be biased for anybody, but your clothes should be formal, suited to your gender and area around. So if you are in Delhi and if you are wearing trousers and a coat, it may be comfortable enough. But if you are in Nagpur, I would say that you tone down yourself when you are dressing up. If it's a winter, do dress up properly and keep yourself warm, because your comfort is very important at the same time. If your exams are in summer, dress in such a way that you feel very comfortable, you are not very sweaty. You remember that your apron, as Dr. Vikas said, that apron has to be clean. One thing. Second important thing which I have observed is that students come up with somebody else's apron, with somebody else's name written, and then they want to cover up with some shit, and they try to
Micropore.
put up their own rule.
Micropore.
And then they use the vodka sticking, which any examiner would take a strong objection to. So I would always say, wear a good clean apron, keep everything ready one day prior. Don't rush to the wards wearing वो apron पहनते पहनते दौड़ते दौड़ते आपको एग्जाम में नहीं जाना है. Keep everything ready. And most importantly, I would say that as have been instructed from first year, keep your hair properly tied up for various reasons. It is not that we want to comment upon the physical appearance of any student or want anybody to be uncomfortable. But when you examine the patient, you bend down, you percuss, you talk to the patient, and your hair coming down, falling in your eyes, in your nose, and then you are putting it back. What you are doing is distracting yourself, the examiner, and the patient. So at least till the examination time, so for 3 hours in the morning or for a day, take care that you are in such a properly attired way that you are comfortable and you are not distracting somebody with your ideas. I always quote an example. आप टीवी वॉच कर रहे हो, न्यूज रीडर न्यूज पढ़ रही है और एक मक्खी आती है और वो बार बार उसके सामने घूमती है, तो वो खुद तो अनकंफर्टेबल है, लेकिन देखने वाले जितने लोग रहते हैं, मे बी मिलियंस एंड मिलियंस, दे बिकम अनकंफर्टेबल कि कब वो मक्खी हटे और वो न्यूज रीडर आगे का बिना आंख हिलाए पढ़े. I always quote this example that do not distract anybody and let not any of your attire act as a makhi on the TV, but wear comfortable clothes, what you have been wearing and you feel comfortable. If you are wearing formal clothes when we are talking about girls, and if you are wearing trousers, wear a long kurta for that and be comfortable yourself. It's not mandatory that you change your attire all of a sudden for your exam and make yourself uncomfortable.
Yeah.
But they have they have to go near the patient, they have to bend down, so they should be properly dressed.
Yeah. I want to give a simple message that practical exam is about what you are going to do for the next 30 or 40 years in your life.
Yes.
So even the dress code is important, because now as a consultant, I would never go to my chamber or hospital wearing a t-shirt, some rock band inscribed on it.
Yes.
Neither will I go to a chamber wearing a jeans pant.
Yes.
So ditto same for the exam.
Yes.
I may have floaters, I may have good sandals, but I would never dream of going to my hospital or my chamber wearing a floater.
Yes.
So the same for the exam.
Yes.
Okay. Again, back to academics. Pradyut sir, what do I need to see in abdomen in respiratory cases?
The whole idea of checking the other systems other than the lungs is to try and find out the findings which correlate with your findings in the respiratory system, and probably you come to a single diagnosis, or at least that can give you an etiology to your respiratory condition. In the abdomen, specifically as regard the lungs, you can look for any what we call as a doughy feel in the abdomen. जैसा आटे का feeling होता है ना, आटा गूंथते समय, doughy feel in the abdomen. That can tell you that probably it's a case of pox. Look for any ascites, and if your case is a pleural effusion and if the case is a female, then you can think of certain conditions, ovarian carcinoma, Meeks syndrome, other things. Look for any organomegaly, any hepatosplenomegaly like that, and or any other masses if you can feel, that can give you or assist you in giving you a diagnosis in your case. These are some of the few examples of what you look in the abdomen. And always, as I told you, if the patient is allowing you as a male, try and look the genital organs as well. That will give you a good amount of diagnosis to your case. The whole idea is to examine other systems so that your findings in your respiratory examination gets strengthened, and try to get an etiological diagnosis to it. Similarly, if you take a history of ulcerative colitis, diarrhea, if we have a case of bronchiectasis, then it can correlate with that finding as well.
Okay, thank you. Now I move on to Shahjahan sir. Same question. What do I need to see in cardiovascular in respiratory case? Shahjahan sir.
As Pradyut sir said, just like GIT, cardiac system is also very closely linked to respiratory system. We cannot simply differentiate one system from other. So starting from pulse, there can be pulses, paradoxes, elevated GVP. We look for right ventricular hypertrophy, percussing the cardiac bodies to check whether there is an enlargement of heart, and you look for left parasternal heave, and you look for a palpable pulmonary component of the second sound, whether there is a loud pulmonary component of the second sound, and there is evidence of pulmonary artery hypertension. Again, I would say palpable P2, loud P2, etc., etc. Then look for right heart failure, such as jugular venous distension, hepatojugular or abdominojugular reflex, peripheral edema, ascites, gross edema, anasarca, S3 gallop, and there is a pan-systolic murmur of the tricuspid regurgitation associated with pulmonary disease. Then, of course, the right heart failure can lead on to left heart failure also, the concomitant left heart failure. All these we should check before having a complete diagnosis. So, but remember, many of these findings may not be visible, may not be got because of the because of the overinflation of the lungs to emphysema or other chronic respiratory issues. So, but you have to be cautious. You have to interpret all these findings, otherwise you may miss the comorbidity, otherwise you miss a complication.
Vikas sir, neurological examination in respiratory case, and to add on to it, the clinical features of respiratory failure.
Neurological examination basically having an important role in respiratory system examination, because many of respiratory disease are part of some syndromes. That syndromes also having some neurological implications, and even most of the disease, just like patients of COPD, having CO2 narcosis. So you first of all you should have the higher mental functions. That before starting the exam, we always mention that patient is conscious, comfortable, and oriented for time, place, and person. So if a patient of CO2 narcosis patient may not have the conscious or the oriented, and most of the time in malignancy cases, the few of malignancies presents only on neurological signs. Just most commonly the small cell carcinoma. Most of the time it appears with brain mets. So the patient will only show the neurological signs only. I can remember recently a 35 years young guy presented with irrelevant talk and abnormal behavior of 2 days. He went to the neurologist. Neurologist ordered a MRI brain, and that saw the multiple mets in the brain. And then he went through the CT chest, and CT chest was suggestive of left hilar mass. And after the bronchoscopy and biopsy, it was small cell lung cancer. So most of the time, the malignancy cases, especially, may present with extra pulmonary symptoms. And if we can discuss the tubercular meningitis, a very important role of higher functions, the neck rigidity and chronic signs. So, and many other diseases. So you should always look the neurological signs in higher neurological functions, any focal neurological deficit, just like weakness of any side, because most of the COPD patients, the chances of CV are very high in these patients, because CV and COPD share a common etiological factors. So most of the time, the patient presented with acute exacerbation of COPD, but suddenly he may have the weakness of unilateral weakness or having the hemiparesis. So you should always look the higher mental functions, the focal neurological signs, the cranial nerve examinations, the local neurological or examination is the most, if we can say that, like in the case of superior sulcus tumor, patient may have the Horner syndrome, patient may have the localized muscle weakness of hand. So you should go through the all neurological examination by one, and you should check the reflex of the patient also to see any local or focal neurological signs.
Thank you. I would move on to Radha ma'am. Musculoskeletal exam in respiratory case. Musculoskeletal exam.
It is also a very important and relevant examination, especially if we look at two different scenarios. One is respiratory system involvement in common diseases like tuberculosis and COPD, where there is a muscle wastage. Then that should be properly evaluated. Or there can be primary musculoskeletal disorder and patient has now presented with some respiratory symptoms. So whenever you examine the patient, the motor system examination should be complete. So when you look at the muscles, comment upon the nutrition, the tone, the power, the coordination, involuntary movements, if any, and of course reflexes. Then you have to even look at proximal myopathy, if any. Then look at the joint deformities, if any, if they are at the fingers, or if patient has a larger joint pain or an obvious deformity. All this must be observed and recorded and then coordinated with other findings. And of course, BMI, which is the first comment when you make about the patient's height and weight.
Thank you. We have an audience question. Dr. Sami Jayaraman from Chennai. He's a very active CCI Life member and he watches every Thursday webinar. So Dr. Sami Jayaraman has requested Dr. Pradyut Waghray sir to talk a little about neck examination in a case of lymphadenopathy, cervical lymphadenopathy, neck examination in cervical lymphadenopathy.
As I told in my earlier this one, neck examination for lymphadenopathy, look for the lymph nodes where they are, either the cervical or the supraclavicular, look for which group they belong to, and then try and find out how they are, whether they are matted, fixed, or they are whether they are mobile or they are hard and fixed, matted, so that can give you a diagnosis. If you have a matted group of lymph nodes, it can say probably your thing is tuberculosis. If it is a fixed hard lymph node, then probably it can tell about any underlying malignancy. And then whichever group is involved, and that also is important to us. And if you are noting any other abscess, many times we get cold abscess. You see a big lump in the neck. And then if you have associated matted lymph nodes, that can give you a diagnosis of tuberculosis. So I think these are the part which you must think of. These are the points you must pick it up whenever you get a case of lymph node on the neck.
And so when we are dealing, can I add something to this?
Yeah.
Yes, please.
When we are talking about examination, and even if this is a query of Dr. Jayaraman, I would insist for all students to know that when you are examining a patient for lymphadenopathy, make the patient comfortable. That is one. Let him know what you are doing to his neck, because you are going to press and try to palpate properly. One. Secondly, warm your hands. Thirdly, stand behind the patient and ask the patient to flex his neck muscles. Otherwise, flex his neck. And then only the muscles would be relaxed and you will be able to palpate and note whether there are any lymph nodes palpable there or not. Otherwise, few of the lymph nodes can be missed if the position is not given properly and not examined properly.
Thank you. Thank you. Sometimes before the exam, someone can get a flu because there is so change of weather, extreme hot, taking that AC or fan in full speed. People can have GI upset. It can occur either from ordering food because no time to cook, or from anxiety can also lead to GI upset. Sometimes there can be a flare in blood pressure, can be a flare in sugar. So basically, Shajahan sir, could you kindly guide what emergency medicine stock should I maintain before my practical? as a candidate?
That is an important question. Let me ask you whether you are writing the students, what about the students or the tray you have to keep for the patients? Which one you students?
For the students, for the student.
For the students of see, we all are medical professionals. We know whether you are having a chronic issue or not. For example, around 5 to 10% of the population is asthmatic. Suppose you are even if it is under control, because not using a controller medication, it is advisable better to take start it before to at least 2 weeks prior to your examination. For example, inhaled corticosteroids, just like even of the day of the examination, because you may be in trouble, because you may be sometimes you may have exaggerated you may sleep during, or you may not be so alert actually. Whether you will not, even if you don't sleep, you may not be alert. So that issues you have to address. You have a low sedating antihistamine if you feel like that. And there is no role for this kind of what I say low motel kind of preparations you take. You first of all you be cool, calm, and confident. Most of the issues will be addressed. And if you have a chronic issue, maybe you are a diabetic, maybe you are PCOD, maybe you are some. See, another unaddressed area is many of the students, many of the doctors even are on medications for depression, medications for anxiety. Don't stop it. If you have to stop it, if you are under control, you talk with your doctor. Don't treat yourself. Even if you are a pulmonologist, don't treat yourself. You have to ask your teachers, ask your colleagues. So if there is depression, if there is anxiety, it is an unaddressed issue. Many doctors have issues. So you take medications as directed by them. That is very, very important. Of course, Dolo is nowadays it's a common brand. People are taking it like breakfast. And if you feel a mild fever or like that, you can take $1. No issue. But otherwise, don't treat yourself. Treat under the guidance of an expert. So of course, you are a doctor. You can ask anyone, no issue. What happens with us is that we often self-treat, even if you have a facility to have the most experts in the vicinity. That should not happen.
So in short, we would say that don't stop on your own if you are already on some medication for a well-defined cause and you have been prescribed by Dr. One. So whatever you are taking, don't stop because exam is there, and whatever you have not taken,
Yes,
don't start on your own. That is important.
Yes.
And the third important is that वो जैसा बोलते हैं ना कि अगर आपको आम खाना है तो सबसे पहले आपको आम का झाड़ लगाना पड़ेगा. तो अगर आपको एग्जाम देना है तो आपको एग्जाम का प्रिपरेशन करना पड़ेगा. So my take on this is always that whenever your immediate senior batch is giving their exam, that is the time when you should start practicing for all practical things which you have already learned for 2 years. Now is the time to become expert and learn the correlation. The best thing for this, what you can do is teach your own colleagues. You explain to them, you ask them questions, you answer their questions, and that would keep you in a habit of thinking fast and correlating and answering somebody, you know. That is what I usually tell my students.
Okay, thank you. And thank you, Shajahan sir, for bringing the brand of the year for India, Dolo, into the question. Okay, Dr. Vikas sir, there is an audience question. Dr. Saumitra Mandal from West Bengal, Kolkata. Kindly enumerate the areas of the chest, because as per him, there is discrepancy among the various books. Some book says 8 areas, some book says 9 areas. So if you could kindly enumerate areas of the chest, Vikas sir.
I think my 3 co-panelists can explain it better, because there are multiple discrepancies in the book. So even Radha ma'am or Shajahan sir can explain it better. Because
okay, Shajahan sir, areas of the chest.
See, there are different textbooks says different areas, but still I think that is not a big issue. See, medicine is an art and not a pure science. There are controversies, but you explain, sir, I have read this from a particular textbook like this. Don't, and you follow standard textbook. That is my, see, how many bronchopulmonary segments. Still, there are confusion. Many people say 10 on right, right side, 9 on left side. Some say 8. When I was an MBBS student, that was it. When even now it is like that. As you said, 2 lungs before COVID and 2 lungs after COVID. So I think you follow a standard textbook. And you suppose even the examiner asks you, see, it is not like that, sir. This is the I have given. Okay, and if the examiner is saying that this is like that, okay, sir, I agree. That's all. That's the only way out, I think. Because even during this discussion will not sort out that problem, I think.
Okay, thank you. We had a question from Dr. Rajesh, Jabalpur, Madhya Pradesh, which we have already answered. Vocal phrenitis and vocal resonance in case of lung fibrosis and lung collapse, that has been encountered already. Okay, next we have from Coimbatore, Dr. Muthu Lakshmi, who is from the PSG hospital. And someone very dear to us is from PSG hospital, Dr. Amutha Kumar, who makes all those CCI gatherings. So Dr. Muthu Lakshmi's question is, how to differentiate bronchial breath sound in upper lobe in an old TB patient, whether it is due to deviation of trachea or whether it is due to fibrocavitary disease. Post-TB patient, bronchial breath sound in upper lobe, whether it is due to deviation of trachea or due to fibrocavitary disease. Anyone can volunteer?
Can I answer one part of it?
Yes, please.
Yes. Usually right upper lobe, especially the infraclavicular region, which is very adjacent to the sternoclavicular joint, would have some amount of bronchial breathing. You may feel. Now, when she's talking about sequelae of tuberculosis, and she's asking about whether it is due to pull of trachea. So first and foremost, one should be able to demonstrate that trachea is shifted to the same side. And if trachea is shifted to the same side, you first auscultate over the trachea and note the sounds which you can hear. And then you gradually go towards the thoracic cage and the upper part which is occupied, where did we say? In the upper lobe. That is the part which is there just above the clavicles and just below the clavicles, that area. You go to auscultate there. And if the sounds are of the same type, however decreasing slightly in intensity, this is all a typical bronchial breathing, which is because of the shift of the trachea. That is my perception and my explanation. Others can add to it. Now, when she's talking about fibrocavitary disease and a bronchial breathing due to that, I don't think that what we talked about pull of trachea due to fibrosis and a fibrocavitary would make a lot of changes here. Because for any type of cavernous bronchial breathing for you to hear, the cavity has to be large enough and the opening to cavity also has to be large enough. Otherwise, you would get an amphoric breath sound. अगर आपको ये bronchial breathing अलग से सुनाई दिया है, the characteristic which you hear on trachea, and I would always tell everybody, please, every day when you examine the patient, do auscultate over trachea and make yourself comfortable and confident about the bronchial breathing which you hear over the trachea. तो आपको ऐसे questions नहीं आएंगे. And then when you talk about the fibrocavitary disease, you can hear even the amphoric breath sound if there is a big cavity with a smaller opening. So type of bronchial breathing would be definitely different in these areas. But everything depends upon the size of the cavity. Just because there is a fibrocavitary disease seen radiologically does not mean it would produce similar type of findings when you examine the patient. If the amount of fibrosis is very large and cavity is hidden into that fibrotic bands, then you may not even hear a bronchial breathing if it is away from the trachea. यानी आप जैसे अगर laterally जाओगे, if you are auscultating on the lateral side of the chest wall, far away from the trachea, and even if there is a cavity inside which is deep down, you will not hear any type of bronchial breathing. That is my perception and explanation. If I made any confusion or a mistake, my panelists are free to correct me.
One thing what I would want to say is everything should start from history.
Yes.
Let's look at the arranged marriage system in India. We first are interested what were the grandparents of the bride or the groom. Then we come to what are the parents or uncle, aunt of the bride or groom. Then we come to what do the bride and the groom do. Similarly, whatever may be the question in a practical exam, your answer should start from history. That think relevant points with respect to old tuberculosis in history. Think relevant points, what can happen if there is a collapse in history. Similarly, what can happen if there is a cavity in history. Go that way, you shall never be wrong. But if you directly jump to a finding and try to explain that finding, then things are going to get wrong. So please start from the history. What were the grandparents doing? Last come, what is the bride or groom doing, or what is the auscultation finding? Auscultation comes at the end. Auscultation comes at the end. There is a suggestion from Dr. KS. I cannot recognize the initials, from Ahmedabad, Gujarat. Please incorporate regarding diffusion. Don't worry, we have a future topic where we shall be talking related to diffusion interpretation in the practical exam. That is not for today. And there is this gentleman from Udaipur, Rajasthan, Dr. Deepak Rathi, who wants to welcome all of us to NAPCON Udaipur later this year. And Dr. Deepak has requested regarding the position assumed by the patient during pneumothorax and pleural effusion for relief of chest pain. That what position the patient will adopt to get relief in pleural effusion or pneumothorax related chest pain. Pradyut sir, if you could kindly pitch in.
I think patient will lie down on the side of the disease that will act like a splint and reduce his pain. That's what I feel. Any other ideas?
In fact, that is the
reducing
that is just the definition of pleuritic chest pain. In fact, if we read the whole definition of pleuritic chest pain, it is exactly described like that. So go just by that. I just got a message from the people who are the technical team behind the webinar that we have crossed over 950 live logins. That is phenomenal. That when we are doing a topic only for PG student exam going, there are 950 plus live logins pan India. That is a very good number, showing how good job our panelists over here are doing. Congratulations to all the panelists who have put in this extra effort for each of the students. There is a suggestion from Nagpur, Maharashtra, and this Dr. Nishigandha Sanjay Gore. I don't know whether madam knows this guy or lady. It's a suggestion that can I request you to please guide newly admitted first year PG. You can take my number, don't worry. I am always there to guide or confuse or whatever. And there is a feedback again from Dr. Sami Jairaman, who has appreciated this panel discussion. Very good panel discussion. Thank you, CCI. Thank you, all the moderators. There is a question from Kolkata, West Bengal, Dr. Dwaipayan Ghosh. Please explain the mechanism of crepitation and wheezing, as I might be mistaken regarding what I learned. Mechanism for crepitation and wheezing. Any of our examiners may volunteer. This is the last question, because after this we would have to sum up. It's already 9:45. So this would be the last question. Mechanism of crepitation and wheezing.
When we go through the mechanism of crepitations, there are two different type of crepitations. One type of crepitations we can see in either pulmonary edema or lung abscess and all. These crepitations are due to the accumulation of fluid in the distal bronchi or terminal bronchi. So that crepitations are due to the passage of air through that accumulated fluid. But the crepitations are here in the typical IPF that are, we can say, the Velcro type of preparations. There, that are the, in the end is inspiratory stage, the snipping up, opening of the alveoli. So these preparations are the sudden opening of the alveoli that are typically heard in end inspiratory phase. And but the preparations due to the pulmonary edema or lung abscess and bronchiectasis, that are due to the accumulation of the fluid, that we can hear the whole of the inspiratory phase. So this is the basic difference of preparations in ILD and other preparation due to other diseases.
Okay,
Atri,
thank you.
If you permit,
Yeah.
if you permit one left-handed person.
Yeah, please, Shajahan sir, please.
I think regarding fleximeter and flexor, I would like to answer that question, if you permit.
Yes, please. Yes, please.
Traditionally, we speak about the flexor and fleximeter. Flexor is the right middle finger and fleximeter is the left middle finger. But ideally, it is the flexor is the middle finger of the dominant hand and fleximeter is the middle finger of the non-dominant hand. So for a left-handed person, he or she can use the right middle finger as fleximeter and the left middle finger as the flexor.
Thank you. Now, as we come to the end, I would quickly ask our examiners one by one to summarize few take-home points. It may be regarding a certain topic preparation or it may be regarding a general tips. Dr. Vikas sir, please.
One thing I want to say, that especially in the DNB exam, there is always a time constraint, because in DNB exam, all 4 cases are long cases. So student is always in panic because of the constraint of time. So I have seen most of the students are started to write in beginning only. So I want to say that you should not, there is no need to write in beginning. First you have examined your patient completely. If the time is left, then you can write. Otherwise, you can tell the examiner by your examination. You shouldn't try to write each and everything on the paper, because most of the students started to write just they do a inspection part, they will write everything. Then they will do a palpation part, they will write everything. So I would like to say that you shouldn't waste your time on writing each and every point. You should examine your patient thoroughly. After that, if the time is left, you can write. Otherwise, you can write the important positive findings only.
Thank you. I have one feedback from Dr. Mohit Bhatia from Varanasi. We all met him at Varanasi this time and he did a splendid job. He has congratulated all of us for a wonderful discussion and he has thanked CCI for organizing such kind of activities. I would request now Shahjahan sir to please sum up a few tips, last moment tips for the candidates.
Be cool, calm and confident. You have put your precious time for the last 3 years to learn pulmonary medicine. One day you cannot explain all these things. Your day may not be that much good. Don't worry about that. Examiners are here to help you, assess you and not to harm you. Good luck to all of you. Thank you.
Very clear cut, very precise. Pradyut sir, kindly unmute yourself. Yeah, please sir.
I think I agree with Dr. Shajahan sir. Please be calm, cool before the examination. Even if you get a wrong diagnosis, don't worry. It is how you arrive at a diagnosis, how you elicit the clinical signs, how you justify your points like a lawyer, how the lawyer argues about this case. That is more important. That will tell how much you know about the subject. As sir has said, examiners are there to help you. Nobody has a vengeance against you. We all want to pass the candidates if you elicit the proper clinical signs. Don't commit blunders in the examination. And wish you all the best.
Thank you. Radha ma'am, you were the revelation today, the most high yield point. So some last points from you, ma'am.
I would take forward what Dr. Pradyut and Shahjahan sir has said, that be cool, have something to eat, don't go on empty stomach. That would be my advice first and foremost. And remember that you have read and you have examined n number of patients. The time has come to put everything together, whatever you have read and whatever you are examining, and we are looking at your capability to correlate and come to a diagnosis. That is all. See, the knowledge is never ending, and we cannot test the n number of books and thousands of pages that you have read. So all we are looking at is, are you able to correlate or utilize whatever you have read and prepared? That is what we are testing in the examination. So be cool, and my best wishes to each one of you who is facing exams in near future, or say even after an year or so.
Yeah. At the end, I just want to say that after our class 10th or matriculation, we can divide into arts, science, or commerce. So medical science is the science where we need to learn the art to pass it to improve our commerce.
Yes.
And I really would like to thank Chess Council of India, who thinks of such webinars which may not be commercially viable at all. We are not talking about any medicine. We are not talking about any investigation. But we are trying to make the next batch of pulmonologists better than us by giving them the 3-4 decades combined experience of so celebrated examiners from the country. So young students would be pulmonologists, would be specialists, would be giants of the future. Chess Council of India will always be with you because we want to unite. We just want to strive for academic excellence in pulmonary medicine, to bring better pulmonary doctors. You may be a pulmonary physician, you may be a pulmonary surgeon, pulmonary radiologist, pulmonary pathologist. We want to bring out the best in you. I want to share this word with all the people watching live, that if you are a life member of Chess Council of India and you have not been incorporated in a webinar, kindly reach out to us. If you reach out to us, we will definitely give you the platform. And I would want to thank the Cipla team who are supporting us in these webinars. I would want to thank all those technical team behind that taking my presentation, looking at this live, that nothing should be uninterrupted live over here. So these things require a lot of effort behind the scenes. And I would want to thank the CCI team, Dr. N.H. Krishna sir, Dr. Narayana Pradeep, who are the founder trustees, the Dr. M Narender sir, Dr. Ravi Dosi, the current president and secretary, Dr. Vijay Kumar Chennam Chetty, who is the webinar coordinator, and he is assisted by Dr. Kirat Sibia, Dr. Shivani, Dr. Nitin Abhyankar sir, Dr. Devi Jyoti Das, who all bring these topics, this concept, and the panelists. We always want to ensure that there are panelists from various parts of India, that people from every part of India should interact over a platform, give experience, either local, regional, as well as national, to give you the best. So from Chess Council of India, I would want to sign off. Have a great evening, everyone. And we shall again come back for a wonderful webinar. Thank you all the panelists for a stellar job. Thanks a lot. Much grateful.
Thank you, everybody. In fact, Dr. Atri, we should say that all our would-be young pulmonologists have to just cross the river or ocean of examination, and all of us are here waiting on the other side or other shore with our open hands, open heart, and open mind to welcome all of them into a wonderful world of pulmonology.
Thank you. Thank you,
And I
CCI.
thank the
Thank you.
CCI for giving me this opportunity, and all my panelists, and of course Dr. Atri, Dr. Krishna, and Dr. Narayana, and the whole team.